Welcome, everyone. I am absolutely thrilled to have you here for today's explainer. We are going to be unpacking the hidden logic and, honestly, the high-stakes medical triage of mental health care. You know, when most of us think about psychiatric nursing, we tend to picture quiet therapy sessions, right? Soft conversations. But the reality? It is this incredibly dynamic, high-pressure environment where life and death literally hang in the balance. It demands rapid problem-solving and just a massive depth of clinical knowledge. So let's map out exactly how frontline professionals navigate these super complex situations.
Okay, let's dive right into this. We're going to be covering the front lines of mental health, Priority 1, immediate safety, managing medical crises, the art of communication, and finally, the legal duty to protect.
Section 1, the front lines of mental health.
So it's absolutely crucial to frame psychiatric nursing not just as providing emotional support, but as a really intense, multifaceted medical discipline. A super common scenario on these front lines is a patient coming in with what's called a dual diagnosis. Imagine a patient who's dealing with both a mental illness and a substance dependency. Say someone who tells the nurse they've relapsed on illegal drugs and really want treatment. Navigating this means coordinating some very complex overlapping conditions. And the absolute best first step here isn't just hooking them up with a clinic doctor or a sponsor. It's actually connecting them with a case manager. Why? Well, because a case manager is that vital link. They're responsible for finding and coordinating community treatment options to make sure both the mental health and the addiction are treated at the exact same time.
Section 2, Priority 1, immediate safety. Now, before any long-term therapy or care coordination can even happen, the patient absolutely must be kept alive and physically safe. I want you to play triage nurse with me for a second. If you have a group of patients and one says, if I fail another class, I'm going to kill myself, another says, when I leave home, I'm buying a gun, a third casually mentions a past overdose, and a fourth tells you they have a necktie in the room they can use to hang themselves, which one of those demands your absolute most immediate intervention? It's the necktie, for sure. The crucial point here is how we actually assess suicide risk. Nurses are evaluating 3 primary things: the degree of lethality, the person's access to the method, and the specific details of their plan. So patients stating they have a necktie right in their room, that implies a lethal plan with highly accessible, immediate means to act on it. This takes absolute priority over historical attempts or, vague future threats, because the danger is literally present right in that very room. But safety isn't only about self-harm, right? It's also about managing aggressive escalations. Picture a client pacing the hall near the nurse's station, swearing loudly, or maybe even shaking their fist in responding to hallucinations. The protocol here is just brilliant in its structure. First, you acknowledge the distress without any judgment, just simply saying, "You seem upset." Second, you use open-ended questions like, "Tell me about it," to gather info without escalating the tension. But physically, you absolutely must maintain adequate social space, strictly 4 to 12 feet. That specific buffer minimizes the client's feeling of being threatened while crucially keeping the nurse safe from sudden physical contact.
Section 3, managing medical crises.
Remember, psychiatric nurses are first and foremost medical professionals. They have to spot hidden biological dangers that are masquerading as, or happening alongside, psychiatric symptoms. Consider a patient admitted because they're feeling depressed over losing a job, and they admit to drinking heavily about 12 hours ago. He has suicidal ideation, sure, but his vitals are elevated, a temp of 100 degrees, and blood pressure at 142/100. In this exact moment, alcohol detoxification completely trumps the psychological assessment. Those elevated vitals are physiological red flags of withdrawal. Maintaining basic physical safety by giving a medication like lorazepam for detox is the immediate priority, long before you can even begin to safely address the suicidal ideation. Now, what's really interesting here is the progressive danger of these medications. Lithium is a super common treatment for bipolar disorder, but the margin between a helpful therapeutic dose and a highly toxic dose is razor thin. If a patient starts showing early symptoms, diarrhea, vomiting, drowsiness, the nurse has to immediately hold the medication and notify the healthcare provider. If they were to just write it off as a normal side effect and give the next dose, the toxicity progresses incredibly fast to severe ataxia, tinnitus, and blurred vision. It is literally a physiological ticking clock. And get this, the medical dangers extend all the way to the dinner plate. For patients taking a class of antidepressants known as MAOIs, a totally simple dietary choice can actually be fatal. They have to stick to a really strict tyramine-free diet. Roast beef, baked potatoes, iced tea, all perfectly safe. But if that same patient eats liver and onions or, grabs a slice of pepperoni pizza, that simple meal can trigger a sudden, life-threatening hypertensive crisis. So nutrition in this setting isn't just about wellness. It is straight-up emergency medicine. Okay, let's test your diagnostic eye one more time. You have a patient with catatonic schizophrenia. They are completely mute and completely motionless. What is the hidden primary physiological threat you need to be looking out for? The answer is severe malnutrition and dehydration, leading to fluid and electrolyte imbalance. It is so incredibly easy to focus entirely on the striking psychiatric presentation of catatonia. But the nurse has to look past the psychiatric diagnosis and realize, hey, if this patient isn't moving, they aren't drinking water, and they aren't eating. Basic physiological stability, keeping the body's fluid and electrolytes balanced, is always the absolute priority before addressing the mental state.
Section 4, the art of communication.
So once we've actually secured physiological safety, we enter the realm of highly strategic therapeutic communication. This is how we guide patients back to reality. A really fascinating concept here is reality testing, especially in group therapy settings. Imagine a client hearing voices saying someone is going to poison him. Instead of just the nurse correcting him, another patient might chime in and say, "You know, I used to hear voices too, but I found out they were just my imagination. Yours aren't real either." This is reality testing. It's a peer-driven process where members help each other figure out what is real and what isn't. They're providing feedback in an empathetic, totally non-threatening way, and it is incredibly powerful for breaking through delusions.
But what happens if the patient has Alzheimer's disease? Imagine an older woman wandering a really busy nursing home hallway, asking people, "Where should I stand for the parade?" Notice the huge difference between a harmful response and a therapeutic on here. Saying, "You're confused, there is no parade," completely dismisses her reality and is just going to spike her anxiety. The real therapeutic art is in redirecting without dismissing. By saying, "Let's go back to the activity room and see what is going on in there," you accept her attempt to find order and gently guide her to a safer, more familiar place. Nurses are constantly actively engaging clients in self-management using very specific therapeutic strategies. For schizophrenia, teaching the client to use conscious self-talk to disprove auditory hallucinations helps them fight back against those relentless voices. Or if you have a depressed patient who is super anxious about riding the bus, you don't just solve the problem for them. Instead, you ask open-ended questions like, what are some ways you can cope with your anxiety to help build their independence? And for acute depression, exploring those deeply hidden feelings of shame, anger, and guilt is absolutely essential to the healing process.
Section 5, the legal duty to protect. All right, so we've seen the medical and therapeutic sides, which brings us to the immense legal and ethical burdens that psychiatric nurses carry around every single day. Consider the behavioral defense mechanism of projection. Let's say a child is brought to the ER with multiple healed fractures. When the nurse tries to give an injection, the mother aggressively shouts, "Don't touch him, you'll hurt my child." Recognizing defense mechanisms like projection, where the mother is literally attributing her own harmful actions onto the nurse, is very often the first critical clue for a nurse to identify suspected child abuse. And when abuse is suspected, the protocol is strict and totally unyielding. The nurse evaluates the child for other injuries, like maybe a low-level fall causing an unexplained break, but they absolutely do not wait around to play detective. They immediately notify the charge nurse and start the legal reporting process. It is the nurse's immediate legal responsibility to report suspected abuse to the authorities, period. They don't wait for x-rays to confirm it, and they definitely don't ask the doctor's permission first. Then, of course, there are those intense situations that bring patient confidentiality crashing directly into public safety. Imagine a patient looks you dead in the eye and says, "I plan to kill my spouse and her lover as soon as I am released." What do? Do you keep it confidential just because they're your patient? Well, the answer lies in the Tarasoff decision, and this brilliantly illustrates how the law works here, mandating a duty to warn prospective victims. In this high-stakes scenario, the nurse absolutely must override typical patient confidentiality. They are legally and ethically obligated to immediately inform the healthcare provider and strictly document the threat. They have to initiate the process of protecting those targeted individuals. We also see this heavy intersection of law and medicine in trauma care. During the acute phase of rape trauma syndrome, where a patient is likely in shock and experiencing emotional numbness, clinical precision has to merge with deep, deep compassion. The nurse doesn't just rush into evidence collection. Step 1 is carefully, gently explaining the forensic protocol. Step 2 is securing the patient's explicit permission to minimize any further trauma. Only then do they actually collect evidence, provide prophylactic antibiotics, and initiate crisis counseling. It's just a profound balance of legal duty and human empathy.
So, we have journeyed all the way through triage, medical emergencies, psychological communication, and the incredibly heavy legal mandates of psychiatric nursing. I want to leave you with this final thought. With life, death, and fundamental human rights hanging in the balance every single shift, how do we best support the frontline professionals carrying this incredible and often invisible burden? Understanding their framework of care, just like we've done today, is for sure the very first step. Thank you so much for joining me on this explainer. I really hope this sparked your curiosity to explore the realities of healthcare even further. Keep learning, and I'll see you next time.